Okay, I think we can go ahead and get started. I want to welcome everyone today to the Rutgers Robert Wood Johnson Department of Medicine Grand Rounds. For those of you who were lucky to be with us last week, we had a really incredible talk by Dr. Michelle Petrie from Johns Hopkins, who gave us a great update on systemic lupus erythematosus. For today's session, remember that to obtain CME credit, you have to follow the instructions on the slide that was shown earlier. And I will also post the code in the chat box. I already did post it. And for those of you who are coming in, I'll post it again in a little bit. Make sure you register for credits today because the opportunity expires 12 hours after the session. During today's session, everyone's going to be muted, but we encourage as much discussion and questions at the end as possible. We'll have some time at the end for questions. So if you have any comments or questions, post them in the chat box. Also, if you prefer, I can unmute you so you can ask your own question if you'd like to do it that way. Today, we're incredibly lucky to have Dr. Nahid Bhadelia with us. Dr. Bhadelia is an infectious disease physician and the medical director of Special Pathogens Unit at Boston Medical Center, a medical unit designed to care for patients with highly communicable diseases. She's an associate professor in the section of infectious diseases at Boston University School of Medicine. She oversees the medical response program for Boston University's Maximum Containment Biosafety Level 4 program at National Emerging Infectious Diseases Laboratories. She's got experience with direct patient care, outbreak response, and medical countermeasure research during multiple Ebola virus disease outbreaks in West and East Africa, working with the WHO and Partners in Health. Her research focuses on identification of safe and effective clinical interventions and infection control measures related to viral hemorrhagic fevers and other emerging infectious diseases. She has prior and ongoing experience in health system response to pathogens, including COVID19 at the state, national, and global levels, including supply chain evaluation, diagnostic positioning, infection control, policy development, and healthcare worker training. She serves on state, national, and interagency groups focused on biodefense priority setting, development of clinical care guidelines, and medical countermeasures research. She served as a subject matter expert to the US CDC in prevention, Department of Defense, Global Fund to fight AIDS, tuberculosis, and malaria, and World Bank. Most importantly, Nahid is a dear friend of mine since residency and throughout my time in Boston, a truly incredible photographer. You should see her work on National Geographic, and possibly the best mixtape creator I've ever come across. Today, Dr. Bhadelia will be talking to us about her experiences with the West Africa Ebola epidemic and how, or if, it prepared us to face COVID-19. Thanks, Dr. Bhadelia.
Thanks so much, Dr. Cohn. And I think if I remember correctly, we used to take turns being the winner of that mixtape contest. So you definitely gave me a run for my money. Thanks so much for having me. I'm gonna jump right in only because I think that what I wanna do today is to weave a story, and I'm gonna tell you a bit about the global health preparedness and the global health security. But as with every presentation, most of them are infused with one's own experience. So this is also sort of my own experience over the last 10 years or so, first with H1N1, then with West Africa, then with Uganda DRC Ebola outbreak, and now with COVID. So I have no disclosure, and all the images are mine unless I've otherwise stated with credit to the person below. What I want to do is just talk about some of the lessons, but sort of set the scene, about where COVID came from. It doesn't exist in a vacuum. And even in the pathways that you've seen the global community take in response to it are carved from prior experiences, and not so distant experiences, even from the last few years. And then talk about new challenges that are posed by COVID and understand that there are possible solutions for these new challenges in the post-pandemic world. So as Dave mentioned, my day job is I work for the NEEDLE, a terrible acronym for Maximum Containment Laboratory. But what makes us different is we're one of only 2 academic biosafety level 4 laboratories for human pathogens in the country. The rest are with CDC, the Army, which is USAMRIID, and NIH. And so the work that we do is generally with viral hemorrhagic fevers and other emerging pathogens. And the advantage of this is, when a new pathogen's discovered and you haven't yet set biosafety levels yet, places like ours are very quick to be able to jump into that to do research, live virus research, which we started doing, of course, with SARS-CoV-2, which is in the end is BSL-2, BSL-3. BSL-3 is what we're doing live culture research in. So what I do is I run the 3-bed unit that backs up the needle. It provides, so it's been around, I've been at BU for almost a decade now, and the unit's been constructed and active for about 7 years, and it provides medical backup. If you remember during the West African Ebola virus disease epidemic, there were returning responders that were brought back to the US, and there were centers that were ready to receive them. Well, most of those centers actually existed prior to Ebola because they were backing up biosafety level labs. So the one at Emory backs up CDC's, the one at NIH backs up its own, of course. And the one that was in Montana, Missoula, was actually backing up the one at Rocky Mountain Laboratories with NIH. And so ours was created similar to theirs, which is, a place where you had the technology to allow safe patient care, and you had staff that are trained to be able to conduct that care and provide the highest level of care while maintaining safety and conducting research for reasons that I'll talk about. But I want to shift back a little bit and make sure we're all sort of have the same vernacular as we talk about this. I teach a course actually at the Fletcher School of Law and Diplomacy on international policy. And I think this is important partly because I think it tells you that there is a precedence to how countries have been beholden to each other for a really long time. This is not something new that's popped up in terms of when infectious diseases threats occur within a border of one country. It's been a long-standing, tradition for countries to create agreements. And so as far back in the modern world as 1951, when there were cholera outbreaks in Europe, you had this International Sanitary Conference in Paris that set standards to, when do we get to place travel bans and trade bans? Because countries are always concerned about placing them too early. If in the future, then that means someone else gets to do that to them. And so there's always been an understanding of what are the requirements, how are countries supposed to let each other know when there's a threat within their borders. And the modern sort of translation of this, after the creation of WHO and the UN in 1969, the international health regulations set similar standards to say the countries should let everybody else in the union know when there are certain diseases. So, smallpox and polio are some of the ones that were on that list. And it wasn't really until SARS, the SARS-CoV-1 and the SARS epidemic in 2000 and the anthrax attacks that actually the international community went back and said, we have to refine this. There was a threat within China's borders. We didn't hear about it until that threat basically, was already exported to other countries. And had we learned about that, what could we have done in preparation? And so the revised international health regulations basically asked countries to let WHO know within 48 hours if there's a threat within their borders, and to build the capacity to develop, ability to surveil, detect, and respond to emerging infectious diseases threats, or really any infectious diseases threats. And it gave the WHO the power to declare the public health emergency of international concern, which is important because, the minute 2005 IHR was passed, since then we've had multiple pandemics and epidemics where WHO has had to declare a public health emergency of international concern. H1N1, West African Ebola epidemic, the DRC Ebola epidemic, and now COVID-19, and if it appears that these types of epidemics are appearing with greater frequency, you're not alone, and there are, for all the reasons that we understand, a greater emergence and both a greater detection and ability to spread new pathogens on the face of this earth. Since in my lifespan, 40 something years, the population of Earth has doubled, and we are now encroaching into natural reservoirs that have been in balance with each other. Animals and pathogens, viruses have been in balance with each other for a really long time. And when you carve a road out of forest where that, that very balanced biosphere exists, or when you replace wetlands with farmlands, what you're doing is creating environments where you have greater human animal interface, and particularly between domestic animals and wild animals, and then wild animals and humans. And as this virus has jumped from domestic animals, wild animals into domestic animals, they eventually jump into us. And the spillover events are occurring with greater frequency because there's a greater chance of that interface. And we have gotten better with detection, capacity, in terms of technology, not necessarily always in terms of reach, for reasons I'll talk about, but we definitely have better genetic, classifications and identification of new viruses. We've just started scratching the surface of that animal human interface with studies that look at viruses that are circulating amongst animals, and the fact that there is a greater connection, right? In 2017, 4 billion people took a flight. I mean, it's not individual people. I'm guessing some people actually took multiple flights that year, but that's a huge number of people flying. And when you think about SARS in 2001, 2002, there's a sort of famous description of the fact that SARS made it from China to North America and Canada and back to China within 72 hours. That was in 2002. This is 18 years later, right? I mean, the speed of travel is immense. And not only that, but for COVID has told us is we're really pretty dependent on each other in terms of both trade, but also in terms of our supplies. So a huge percentage of the US's essential supplies, as we learned, as well as our personal protective equipment, are actually created in India and in China. And that dependency is important in terms of approaching new pandemic threats. So, how do we? I'm going to move through this fast, but I go through this because I think it's sort of important to recognize where we start to fail. Like, if you really want to detect the spillover events, which, by the way, 2/3 of new pathogens that we're discovering, human pathogens that we're discovering, are actually zoonoses. So they're jumping from animals into humans, and majority of them are RNA viruses. And so to detect that spillover event that has now made it into a human population, what you need is first a patient to recognize that they're sick. In majority of the big studies that are looking at that human-animal interface, what you're seeing are that humans sometimes at that periphery, particularly around sort of wildlife, may have antibody evidence of infection, but they may not have had any symptoms. In most cases, viruses, when they make this the jump, are not able to cause human disease. It's sort of the right combination of that multiple opportunities that then leads to the right virus that might cause human disease. And over time actually also be a pathogen that can be transmitted human to human. So imagine how frequently it must occur when we are seeing, enough pathogens to now discover that they're pathogens that are human pathogens and causing human disease. So you have to have patients recognize they're sick, even if they are symptomatic. If it's nausea, fever, vomiting, there's a whole lot of endemic infectious diseases that fit their profile, and people may not seek care, or they may not have access to care. There's as we all know, there is a huge percentage of the world population that still doesn't have access to primary care. That inability to sort of access care in the setting of suspicious symptoms generally leads to delays. And then, if it is a pathogen that's transmitted between humans, you now have a cluster before even the first patient gets to care. You need to have a clinician that actually recognizes when a person presents for care that this is an uncommon disease. And there's a study in 2014, I believe, at WHO, that 60% of cases of malaria in the world are treated empirically. I mean, they're not diagnosed. They're given malarial medications. And any of you who are in the audience who worked in resource limited settings, you know that that's actually pretty true. Most people go to the pharmacy and get anti-malarial drugs. And generally in that setting, what happens is a person goes home, doesn't get better, and they come back. And that delay, again, is what's sort of allowing continued transmission within the communities. You need to have laboratories that test and confirm uncommon diseases, and this was the case in West Africa. The index case in the West African Ebola virus disease epidemic was actually a 2-year-old boy in Guinea in December 2013, in an area of the world that's seen just devastating amount of deforestation over the last 10 years. It wasn't really until March 2014 that it was recognized that the pathogen that was creating these clusters of infections was recognized as Ebola. And the reason it took that long initially was, that Ebola wasn't suspected in West Africa. It had never been discovered before. But the second was there really were no laboratories that could analyze that virus. It had to be sent to DRC to get analyzed, to be recognized as Ebola. And then you need to have public health systems that are functional enough to report the threat up, and a national system that reports down with enough resources. So you need that resilience in the healthcare system, ability to isolate it, ability to have personal protective equipment, the ability to quickly ramp up all of those resources and start doing the epidemiological work that's around it. And then international partners that respond quickly in response to that. But we fail at that first level, right? So just again to say, all the photos are taken with permission, even and when they're patient photos, most of them are, the identities are removed and they're taken with permission. So at the end of all at the terminal end of all international surveillance for infectious diseases are communities that don't have access to care. We fail at that first mile in most cases. And the reason we're always behind in making these clusters, to keep these clusters from becoming outbreaks, which become epidemics and then pandemics, we fail at that first level in most cases, particularly when they're diseases that are arising in lower resource areas versus, high resource areas. But there's a special, actually, not just, and it's not just those challenges of the healthcare system or the public health system itself. There's some very unique challenges to emerging infectious diseases compared to other pathogens. And that's the fact that, part of the issue is you learn about the pathogen as you respond to it. In prior years when I gave this talk, I think that I had to go through to explain that to people, but we are living it right now as the global community, as a global healthcare community. As we know with COVID, our understanding evolved from how this disease was transmitted, the asymptomatic, the ability of the disease to transmit asymptomatically. That evolving scientific knowledge is creating a shaky ground, upon which we create our healthcare policies. Who wears personal protective equipment within the hospital? What type of personal protective equipment to wear? All the way to how we respond. Who do we contact trace? And as that knowledge sort of evolves, it's almost as if your first 100 patients are constantly teaching you about the next 100 patients. We learn more about disease pathology. We learn more about long-term effects of a virus. And the other difficulty with most of these pathogens is that, as opposed to diseases that we've sort of have established diagnostics for, and not only the technology itself, but our ability to have validated them for that disease and our ability to place them within different elements or different levels of healthcare system, right? So if you have new pathogens, new diagnostics, antigen versus PCR, in most cases, if you've had them around for a while, you've had a chance to create testing algorithms. You know what two-step algorithms should be. You sort of had experience in emerging pathogens. The way diagnostics are created is the sharing. It starts with the sharing of genetic material. And here's where one of the major sort of tensions in international health systems or international health regulations sort of exist. It requires, and China did that, at the beginning of January, they shared genetic sequence by dropping it into a public repository that was available for others. They didn't share the virus, they didn't share the genetic material itself, just the sequence off of which the PCRs were created. And soon after, the US actually had their own, and we had our own endemic cases, and we were able to sort of get a capture. That early cases in Washington actually became the basis of a lot of the early diagnostics that we have. And therapeutics. We don't have facile therapeutics. And so we depend on a lot more mitigation measures than we would, in other responses. You also have to have balancing of the research and responses, right? To develop those therapeutics, to develop those diagnostics, you need to conduct research alongside your responses. And there's this eternal tension of how do you infuse both a balance that's, doesn't take away resources from the response, but also that it's ethical, in the setting of an emergency. How do you conduct research? And this comes up over and over and over again. This photo is a photo from West Africa and one of the Ebola treatment units that I worked in. And you can sort of see the level of data that we had was of paper, and you couldn't even take those pieces of paper out of the hot zone. The ability to collect data, the ability to conduct research in an ethical fashion becomes really important. And then the other part of this is, I do not envy governments making public health policies in these settings, because as science changes, so does policy have to change. And you can see that around the masking controversy that's been created about how, scientists initially said, do not wear a mask, and then they said, wear a mask. So just encapsulating the impact of Ebola, of the Ebola virus disease epidemic, and really what was potentially 2 very life-changing years of my life, into the next couple of years, the next couple of slides here. But the West African epidemic basically started in 2013. 2.5 years later, accounted for about 28,000 cases and 11,000 deaths. Literally collapsed the routine healthcare in those countries, even though less than 0.5% of the population of West Africa is actually affected or actually had Ebola itself. More people died because of Ebola than of Ebola, as Paul Farmer said in the past, because what you saw was there was a study in October 2014 that showed that 80% of clinic visits in Guinea and 60% of inpatient hospitalizations dropped. And you had loss of healthcare workers, right? And across that region, the 3 main countries that were affected in Guinea, Liberia, and Sierra Leone, over 800 healthcare workers were infected, and almost 500 died. And you're talking about countries that at baseline have very little physician or nurse to patient ratio. Sierra Leone, for example, has 2 physicians for 100,000 patients. And that loss is felt immensely, and it bore out in the years after, where you saw vaccination rates go down. Even towards the end of the epidemic, we dealt with measles outbreaks because vaccinations were down. Infant mortality went up, maternal mortality went up, and the financial cost, across those countries were like $4.3 billion. So my own experience in West Africa, I was deployed 4 times, twice in 2014 and twice in 2015. If you're looking for me on the picture on the left, I'm always the shortest one in every photo. So I'm the short one on the left, underneath all that personal protective equipment. And this is from my first deployment in Kenema, along with my colleagues. And so that what I'm presenting in the next couple of slides are both culminations of the WHO's own analysis of its response, but some of this is personal experience. So the way to understand this is, this not just applies to Ebola, but you'll see how this applies to COVID as well, as opposed to earthquakes. When you have an epicenter, an earthquake happens, you set up an emergency coordination center, your treatment, your security, your logistics. The trouble with emerging infectious diseases outbreaks, or any infectious diseases outbreaks, is that epicenters keep changing. And particularly in societies where there are not as many resources at baseline, you're slicing that, that resource thinner and thinner to try to get those resources out to the new epicenters that are occurring. And you saw that here in the US with the spread of COVID, where Northeast and West were then first dominating the needed resources, and then the South, and then the Midwest. And that shift in epicenters requires a strategy. It requires planning to move, limited resources in a timely, proactive manner to where you see the new cases arising, so they don't become new hot zones, which of course we haven't been as good at here in this country. And then you had community patient distrust, because these are communities that are, again, these outbreaks, they became this big, not in a vacuum. And these are communities in West Africa that were, at least Sierra Leone and Liberia, were devastated with a civil war, a violent civil war, about 10 years, a decade before that. And so there was a lot of distrust with the government already. And what didn't help was, you had, on top of that, you had sort of international media and public response as the first Americans were brought back in August 2014. That was just out of control. I mean, I remember headlines like, is Ebola the Al-Qaeda of bioterrorism? Something like that. It was ridiculous headlines that basically led to out of abundance of caution, the tactics that actually hurt the response itself. So commercial airlines stopped flying, commercial shippers stopped shipping. And in August, at the last week of August, when I was in one of the ETUs, we started running out of personal protective equipment because there was no way to get anything into the country because of abundance of caution. And we were cutting up tarp, to wear that as part of the personal protective equipment on the outer layer. And in prior years, I would tell the story about how our logistician would cut up tarp to make up the apron on the outside of it. And I would get this gasps. And now I don't, because, our own healthcare workers here in the US were putting on trash bags as the outer layer to their personal protective equipment. The failures happen very quickly. Inability to meet needs in the middle of epidemics happen really quickly. And we've lived that now, in a way that very much echoes the experiences that I had and others had in West Africa. The kind of things that you see here in terms of challenges, you will recognize them as healthcare workers who are on the front line here in the U.S. as part of the hot zone. The inability, so the illness among healthcare workers, right? And in Ebola, it's a bigger issue even because the mortality is so much higher. But anyone who's sick or exposed leaves, and so you have diminishing number of forces on the front line. The limits that you have in personal protective equipment themselves, the MSF PPE that you see on the right here. I mean, they say you can only spend an hour in there. The WHO PPE is about 2 hours, 2.5 hours, and we were pushing it much, much longer, unfortunately, than that. But that limits the amount of care you can provide at bedside. And in most cases in Ebola, as it is, in COVID, but even more so in Ebola, this is a nursing heavy disease. Emory had to give 10 to 12 liters of fluid resuscitation, and that requires being at the bedside. And so in August, November, when I went back, I don't think it was that much better, but in August, there were 100 Ebola patients to 4 clinicians at any one time within the hot zone. How many people do you think I gave 10 liters to? We were lucky if we got a liter in to about 25%, or 2 to 25% of our patients. And so that along with, lack of advanced diagnostic, advanced laboratory support within the ETU, it was basic supportive care, and the mortality reflected it. You had mortality in most of those ETUs of 60 to 70%. And when I look back after my experience in West Africa, and this was true, this got better towards the end, maybe by December of 2014 to January of 2015, a good 4 or 5 months after the WHO declared this as a public health emergency of international concern is really when majority of the resources started hitting the ground. The quality of the data, the quality of care that I saw in my own experience in West Africa was very similar to the quality of care that was published in the WHO bulletin for the first Ebola cluster of cases in 1976 and 1979. The care for Ebola hadn't changed between 2014 and 1976 because nobody had made for that push. It was never, it is a perfect example of how you can, think that a disease is as severe as it is, but the mortality of that disease a lot of times affected by the healthcare systems in which it bears out. And it certainly has been true of Ebola, and I'll tell you in a little bit in terms of what happened in DRC. The other part, and this again will ring a lot of bells because the experiences that we had in Ebola and have borne out in COVID, because there are very similar concepts, ethical concepts. The one thing that we saw, with these high mortality rates and not a lot of supportive care or of people available to help, you saw clinicians sometimes, start looking at animal data and cell data and saying, oh, immunorone, that seems like it has some benefit, in Ebola, let's start giving that to our patients. And there was a Ebola treatment unit that gave 100 consecutive patients amiodarone, with no evidence, no clinical evidence. It's an off-label use of a drug, and then publish that data. And so here's the tricky part. Where does off-label and compassionate use end, and where does research start? And in that setting, are you basically conducting research without providing the human subjects or protection that someone might have if this was a research environment? And so And we saw that also with the returning responders. All the Americans, the Europeans that were flown back received just the kitchen sink of experimental therapeutics because nobody wanted to get a placebo, even though there was not enough proof in each of those different, the small RNA, Tickmeyer products, the ZMapp, which is a monoclonal antibody. There was just everything thrown at people. And in retrospect, I think what you recognize is that compassionate use makes it hard to figure out if something is efficacious. And it's the concentration on compassionate use drugs, which we clinicians in particular, we want to make that available to our patients. It creates a tension because, as you now know from COVID-19, that basically delays getting answers about the efficacy and carries the marginal cost of potentially society investing in a drug and generating and manufacturing a drug that may not be efficacious. And this was a lesson that was already learned after 2015, right? We didn't have to wait until COVID to learn this. The international community sort of very quickly recognized this. Other questions that came up were what medical treatments should be deployed and who decides, right? If something is on the pipeline, and Ebola was easy because DOD had spent decades coming up with vaccine candidates for Ebola and Marburg, which is another viral hemorrhagic fever. And so it was really making a decision by the US governmental partners about what would be available to sort of deploy, and the decision by the host governments to say, all right, that seems like that's a treatment that we want to use. But who decides, particularly when there's jockeying at multilateral level? In DRC, this played out because you had multiple vaccine candidates that were being deployed in emergency setting, not just by the US, but then also by China. And so multiple countries sort of competing within this field to try to get their medical countermeasures tested. So there is a health security perspective to this. There's a national security perspective to this. If you're a government that's developing medical countermeasures for these drugs, you have to wait until there's an outbreak to test them. When there's an outbreak, there's an outpour of all these products that appear on the scene where people are competing to get this tested, because if there's no outbreak, you can't do phase 3 trials. This is sort of the weird tension of a lot of medical countermeasures. And that's playing out now. If you look at COVID evaluation for vaccines, the reason there might be a delay is because you need to be in areas where there's enough cases for us to see natural sort of efficacy of these drugs. Then there is what is the other concept of this that comes up all the time is, at what point do you reach enough data to say, I can no longer maintain clinical equipoise? The concept that you can no longer maintain neutrality about whether there's a difference between placebo and the drug. And with emerging pathogens, this happens often where you get to a point in trials where there is some signal of evidence, and you may have a portion of clinicians who say, well, I can't withhold this anymore because I believe that this has some benefit versus placebo. And then what's an ethical design? Because if placebo, and COVID's slightly different, but again, not by that much. I don't know how much difference mortality level makes, but in Ebola, the question was, placebo is not acceptable. People will be willing to take that risk to take the experimental drug, even if it doesn't help and it might potentially hurt, because they're going in thinking I have a 60 to 70% chance of mortality anyway. And so if placebo is not acceptable, what is an ethical research design? And then how do we make research equitable and just and fair once there is efficacy to get those samples out there to everybody? The other element that came out during this period of time was the struggle about genetic material from resource-limited settings being taken out of those countries. Scientists sort of pour in to help to diagnose patients, to care for patients. And there was a lot of controversies about how UK, Public Health England and others actually took entire hundreds of diagnostic samples with the genetic material of the population in Sierra Leone and Liberia back to the UK. This is an ongoing struggle to create equity in research, to not just for researchers in resource-limited settings, but also an ongoing discussion, even when it comes to novel avian influenzas, like H5N1, this came up with Vietnam, about what happens when a country gives genetic material. What right do they have, or what should they be given back if therapeutics are created based on those genetic materials of both the viruses and the people that then those were shared by? So that's It came up in COVID. And if you're interested, I would read around Nagoya Protocol, which is an interesting sort of discussion around biodiversity and balancing that, because you also don't want to put barriers into place where you can't take any samples out of the country and there's no capacity to do the research in country, right? The work has to be creating capacity in country so you don't have to take the samples out. But how do you do this during emergencies? So the basic truth and lessons for Ebola, where you're born decides if you survive Ebola. The mortality rate in West Africa was 60 to 70% in 2014. In returning responders is less than 20%. And some part of that may be just difference in populations, but a huge part of that is the care that people got. The other is, in my third trip, I actually did training for Ebola survivors. And so this is a training of Ebola survivors here that you see, and 50% of them are already experiencing post-Ebola virus disease syndrome. This entity that we discovered that people who survive Ebola, percentage of them continue to have debilitating physiological presentation, and in some small cases have virus in immunoprivileged sites after survival. And there was an uproar. How do we not know this, that Ebola could do this? And when you went back and asked survivors of other Ebola outbreaks before the West African one, actually a lot of them had this. It's just that we don't stick around as an international community. When these outbreaks happen in resource limited settings, there may not be the healthcare infrastructure to give longitudinal perspective to how these diseases play out. And the international community leaves after the acute response. And so it becomes so important, and you're seeing this play out in COVID again as well. It's so important to have a longitudinal perspective of how an individual experiences this disease, to understand the full natural history of an emerging pathogen. And I hope I've convinced you of this, which is that you cannot separate research from care when it comes to emerging pathogens, for all the reasons that we talked about. And and the international community, the three big, if you're interested in learning about this, three big sort of changes or organizations or initiatives that were started after West Africa reflect those lessons. First, there's a global health security agenda, this multilateral agreement or initiative, along with hundreds of academic centers and private funders, that came together and said, only 20% of the states that signed on to the international health regulations actually have the capacity to surveil, detect, and respond. We're failing. I mean, no wonder these outbreaks are becoming epidemics. We have no levees. We have no way to keep this flood from rising. And so one of the main goals of the global security agenda was to identify the key components that are needed, 13 action packages that focus on everything from laboratory capacity to healthcare worker training to antimicrobial resistance work to vaccine development, biosecurity frameworks, and then to do voluntary joint external evaluations of countries across the world. And that's what we were in the middle of doing until the pandemic hit. The other initiatives were one by WHO that focused on developing a research and development blueprint that basically identified 10 likely diseases that are likely to cause epidemics or be a public health threat. And number 10 was disease X, which most would argue is COVID-19, the disease that we don't yet know, but could appear on the international scene and wreak havoc, which of course it has done. And Coalition for Epidemic Preparedness and Innovation, again, a private funders and multilateral agreement that identified 2 or 3 diseases in each round to invest in developing vaccines and therapeutics for. And so the first cycle of this was Nipah virus, MERS, another coronavirus, and Lassa fever. And the goal was, to do for those diseases what the DoD had done for Ebola and Marburg, which is generate these candidates that are ready to go when there are outbreaks, so they're ready to be tested. So in the middle of all this, you had the DRC epidemic that occurred, and most of my work over the last 4 or 5 years, and actually I was telling Dave, I'm concurrently in another Zoom meeting in Uganda right now. I know you can't tell, but I'm also present there. So I have to make sure to log off. So the last 4 or 5 years I've been in Uganda working on sort of the most recent DRC Ebola virus disease epidemic from the Ugandan side. And so this is on the right, the gate that you see on the other side of that gate is DRC. And the North Kivu Ituri sort of outbreak outbreak that happened. There have been 3 outbreaks in DRC in this period, 2017, 2018 that just ended, and a new one that just started again. The lessons that I think what you saw was there's a lot of people who were part of the West African outbreak epidemic that actually moved on to be responders to the DRC epidemic. And what we all brought with us was this understanding that care, the level of care, the standard of care needs to improve for Ebola virus disease patients, not just from a humanitarian perspective, which of course it should, but because how can you say anything about the efficacy of a therapeutic when you don't control the baseline standard of care? Right? If you at least give a minimum amount of standard care, you can say with greater confidence that a drug that you're giving makes a difference or doesn't make a difference. And so what you saw are innovations like this one, which is the cube from Alima, which inverts the infection control paradigm and allows you to give better nursing care to patients, and you only have to go in for a shorter period of time. But this is like $10,000. What are the chances that DRC is going to be able to afford it, that other countries are going to be able to afford it? And what you saw over time in DRC outbreak is that the country adapted it to low-tech technologies where the fourth wall was basically glass, and they were able to put oxygen concentrators and more advanced sort of nursing capacity to that. So it was adopted to cheaper, more sustainable versions that still improved care. The other thing that changed is WHO, changed its guidelines. Finally, after 30 years of knowing about this disease, pushed more advanced, optimized standard of care guidelines that improve provider to patient ratio, unheard of before this, to give shock medications, inotropes and corticotropes to patients in resource limited settings. And here, they pushed aggressive shock management, ability to give norepinephrine in ETU settings, pushed the envelopes in renal and pulmonary support, and then, imaging. All of these were absent from any of the prior Ebola virus disease guidelines. And the other thing that they did was, as an international community, we came up with, on the bottom, you see an understanding that compassionate use can't exist in a vacuum, or off-label use can't exist in a vacuum. If you're going to give it, it has to be on a roadmap towards a randomized controlled trial. It needs to be in agreement with partners that these are the drugs that need to be tested. And if you do use off-label use or compassionate use, it needs to be used under the MURI platform. So that's the document on the right and the bottom. This monitored emergency use that at least makes available an ethical framework on which you use off-label or compassionate use drugs, and with the goal that you're going to move towards setting up an RCT in the meantime. And that's what happened in DRC. There was a PALM trial that tested 3 monoclonal antibodies, including a Regeneron product, very similar to the one that's being used in COVID right now, against a remdesivir, which is the antiviral, which of course is also in use right now with COVID. The issues that came up, and I'm just not going to go into this for the sake of time, are, now you have data in a vacuum. Data is coming out. So how do you take this data and interpret it against all the caveats that go, with, well, was this conducted the right way? Did the logistics in the field affect the data? And then, how do we share that in real time with stakeholders and make policies and public health agenda based on that? How do we take more scientific data back to adapt the trials as we get results out? And you'll see this sort of play out, and you're seeing that play out with COVID-19, for example, because, recovery, of course, added Regeneron's product recently, given the fact that it's a new drug that showed, more promise. So then you have COVID that appeared on the scene, and it was only a matter of time. I think most of us in our field sort of knew that this was coming, that there was going to be a respiratory virus, and it was. That when it did, things might be bad because we exist in what someone's previously called a cycle of panic and neglect. Every time there's an epidemic that scares the world, we put a lot of resources in it. Every time it's over, we take the resources away. We're back to sort of depending on this political cycle that funds or defunds pandemic response. And in resource limited settings, including our work in Ebola, for example, in Uganda, for example, it's interesting, the Ebola affected countries were able to adapt a lot of the existing infrastructure, including emergency coordination structures, research, framework that was used for Ebola for use in COVID. They had established risk communication strategies and surveillance that had improved. It's not amazing, but it's definitely improved because of the Ebola response that was used towards this. And there was a lot of experience in PPE and infection control planning. not as good as you would want. If you're interested, the article on the right in the Atlantic in February that I published sort of talks about how we may never know the impact in many resource-limited countries, and what those gaps in the healthcare systems are that would potentially never give us a sense of the access mortality in those countries. So just for the sake of time, I won't go into this too much, but I'll just say that there are echoes, right? I mean, from what I said about, you recognize this as a bedside perspective. This is our own bedside perspective here at BMC. We're a safety net hospital. 75% of our hospital was COVID patients, and at some point at the beginning of April or end of March. 2/3 of our patients were African-American or came from Latinx communities. There's immense burden that's borne by minorities, and that's sort of something that plays out all the time when you look at outbreaks. Outbreaks take advantage of fault lines. They prey on people that we leave out in the cold, people that don't have coverage, people who may be sicker at baseline, people who don't have as much protection when they work on the front line. And it runs through families. Some of the most traumatizing moments that I had as an Ebola, ETU physician, where when I admitted entire families and I watched them slowly die one after another. Because of lack of resources, because it's a caretaker's disease and people are taking care of each other and they're getting admitted. I could tell you I had a similar experience in the spring walking into BMC where I saw entire families being admitted, particularly from, socially disadvantaged or economically disadvantaged communities where essential workers were part of the family and they brought the disease home, and then, their elderly parents got it or their kids got it. And so there would be moments where I admitted, we were taking care of someone and their parents at the same time in ICUs. It runs in families. It runs through families, right? Because of what we talk about. And the long COVID component. The fact that, this disease too has that component of ongoing potential, impact. So here are some of the benefits that and sort of innovations that we've adapted to that didn't exist, but the ability to use preprint service, with all the risks and benefits that you can imagine with it, but putting good data out there, good potential studies out there early helps with the response because people can modulate and change their policies and procedures, but it carries the risk because there's bad science as much as good science. And now there's growing evidence that preprints might be used for political purposes, where they're not going through peer review and there various actors that are publishing preprints simply to push a political agenda. Then you have the other lesson is their creation of these research networks. There were hundreds of hydroxychloroquine trials around the world. They took millions of dollars out of the response. And in the end, the answers that, this networks that gave the answers that we needed were actually these preset large research networks, like the WHO Solidarity Trial, which, by the way, the results are coming out next week. NHS's recovery trial, and of course the US ACT and Active Network, which have sort of given us data on remdesivir, and soon will be giving us data on monoclonal antibodies. And Operation Warp Speed, which is, I think, of all the things that we failed at, the one thing that we did right in this response is Operation Warp Speed, because the government took the risk from the companies, invested in these trials, and then built manufacturing capacity and bought the first doses, which then pushed a lot of drugs into development and vaccines into development that otherwise wouldn't have been pushed. But we failed, right? I mean, their data now shows that the disease was already transmitting within our borders early January. And while we were still looking at the 5 countries that, people had travel history for in March, I mean, it makes me shudder thinking back at this, that there were plenty of patients that I took care of in February that I was pretty convinced had COVID. If you're interested, this is one of probably many, but this most recent task force report came out in the global response, including the US response on COVID-19. That's very helpful from Council from Foreign Affairs. And what they say basically is that we had these major failures in testing to begin with, but we compounded them because the US national strategy was just fraught with miscommunication and with downplaying the effective, the severity of the virus, the lack of federal response, as we've talked about, and pulling out of the WHO, which we've done. US and China are one of the only two countries in the world that have not invested in COVAX, which is a WHO initiative to try to get vaccines to every part of the world. So last slide, main lesson so far on the global level, I think, the global supply chains are not as prepared. It's fine if there's one, fire, but if the whole world is on fire, we can't keep up with the strain. We can't keep up with supply chains around personal protective equipment, around medications. And so we need a new way to sort of approach this. In the US, what you might see is repatriation. A lot of the industries, for personal protective equipment is essential medications. But what about resource limited countries? Uganda, I mean, we're just having conversations about the fact that there's no N95s available, period, in the country. And then global collaboration needs to continue to create that scientific evidence quickly. The fact that pandemic response is so vulnerable to political interference, I don't think we could have ever imagined that. I don't think we could have ever known how vulnerable. I mean, this is not about, forget US politics, but the fact that politics could completely alter the scope, the arc of the pandemic, is I don't think anybody appreciated that before this. The fact that controlling the virus is probably the only way to survive economically. Austin Goolsbee at University of Chicago gave a really great recent testimony to the Senate Judiciary Committee. His work is great, and Brookings actually has a great report on this, saying that the US, handled the virus the worst, and we have the highest rates, and we have the highest economic effects of this. We had 5 times as high as rate of unemployment as any other OECD country because we didn't control the virus. And then equity in terms of distribution of therapeutics, and the fact that vaccines and therapeutics are only part of the problem. Just to give you a sense, in DRC, the most recent outbreak, we had a vaccine, right? The RVSV Merck vaccine was distributed, and we had Regeneron, which from the PALM trial told us dropped the mortality of Ebola to 6%. And yet, do you know what the mortality of Ebola was in DRC? 60%. Therapeutics and vaccines are not silver bullets. They're part of the tools that we use to help improve our response. But this, I think, in my opinion, is the reason that we've been so bad at dealing with this. It's almost easier to deal with Ebola. It's easier because it's visible, you can see it, and it's much harder to tackle COVID because it's in that in-between space. And we don't know how to deal as society a risk that to some people carries no risk, and in others, it just devastates their entire families, and it ends lives. And we don't know how to strike this balance. So I'll end there. Thank you.
Thank you, Nahid, Dr. Badeli, sorry. Thank you, that was fantastic. I think, one of the questions that I had before I jump into the chat was something you touched on about, I love that slide, where you were born determines whether you survive Ebola or not. And you talked about it a couple times about how that's similar with COVID-19. And we're actually gonna have our grand rounds next week by Sabia Hussain and her group, looking at how the social determinants of health is dictating the impact of infection and mortality and morbidity on patients with COVID-19. So I guess, this is kind of an overarching question for your whole talk, but how do we navigate these social determinants of health with limited resources, with limited knowledge, and lack of clarity about what's going on, what's going to happen?
Yeah, it's hard to know. I think it was true of Ebola. I think it's true of COVID, that to do this in the middle of pandemics or epidemics is really hard. These are efforts that need to start way before, and people talk about this in DRC about like, how could we have done this better? We need to have created that equity to begin with. But, when you look at the vaccine and distribution of the COVID vaccine, you could make it more, equitable. You could, and I saw a great AMA webinar on this yesterday about, what ACIP is going to be doing in terms of distribution of this, of creating new venues and points of care to make this available, and also taking getting rid of everything else around it that might serve as a barrier, including, sending out the vaccines with personal protective equipment, with the needles, with everything that's needed. So it's not just some other parts of health systems that might affect it. I think those types of innovative approaches, that bypass the existing, weaknesses in some of our healthcare delivery systems would be one way that I think we could approach that.
There's a question about preferential protection or preferential treatment. You also touched on this with limited resources. We had a grand rounds in March by Ira Bedzo, who's director of biomedical ethics at New York Medical College. And we talked about this, but how do you determine, I'm sure this was more of an issue, this was a fear that we had early on with COVID, that some places had more of an issue with than others. Unfortunately, I don't think that us here had as much of an issue as other places in New York and northern New Jersey and in Boston. But in situations where, you have two patients and one is a healthcare worker and one isn't, one is somebody who's young and another person who's older, how do you, and you have one vent left, you have, one run of remdesivir left. How do you determine how you're gonna treat them?
I hope we never have to get to that point, because as someone who did that at bedside in Ebola, I think those are probably the moments that changed me for the rest of my life, making that triage at bedtime. And I think one thing that a lot of the states that did that I think were great, including Massachusetts, is actually take this out of the hands of individual physicians or even individual facilities. In Massachusetts, the state bringing a lot of facilities together put out state level standard of care, crisis standard of care guidelines, which were pre-established, so everybody sort of knew. And it of course received criticism because, does that mean that if you have multiple comorbidities that you may not qualify for these types of things? And I think it was, these things it's never going to be pretty. The point is to never get to that point where you have to make those crisis standard of care decisions. But I could tell you the way that this usually played out in resource limited settings where there were no crisis standards of care. The healthcare worker gets the preferential treatment because they are part of the fight. And by saving them, and we did that, we had to make those decisions in Ebola. By protecting them, by saving them, we're continuing the fight against a pandemic.
Painful question, even more painful answer. Is there a rapid response team that can cause political boundaries to enter zones where there's concern for an emerging pathogen? Is that the CDC or WHO? And were they able to enter China across political boundaries? So navigating politics with healthcare.
Yeah, so this is the underlying thing. You can't go into any country without the host country's permission. WHO never does, no party ever does. You always need the host country's agreement in the middle of a pandemic, and WHO becomes a technical partner for that host government. And then there's an agreement with all the rest of the NGOs and INGOs to try to get understanding of who's going to do what. So whether it's actually the response or it's investigation, as was the case in China in terms of getting a sense of how much China shared. Are we recording this? We're not, right? Okay.
Yes, yes, we are, but we can. You don't have to have it posted. It's up to you.
That's okay. What I was going to say is, I think China did better this time around than they did last time around. But what I was going to say is that most people would agree that China lost really valuable time. Their frontline providers told them how bad things were by beginning of December. And for 2 or 3 weeks, they tried to suppress those voices. And I think that if they had shared that severity of voices, then I think all of us would have been farther ahead. So they did mess up in that way. And the fact that US was not present, and we were not part of that trip, is hurtful to us, which is why we should never have pulled out of WHO, because what's happening now is, I wear 2 hats. I have the medicine hat and I'm an international affairs person, right? And so, of course, I'm looking at this from a global health security perspective as well. And this is true. When the US withdrew from WHO, China became the most powerful body within the WHO in terms of helping, determine the agenda, which is it good, is it bad? Well, it's not good for the US, let's just say that. So no, you can't enter a country without the permission of the host government.
I'm going to unmute another old friend. I think she should.
Hey, it's Leanne Chen. How are you, Naheed? It's so wonderful seeing you. It's a wonderful talk. And I wanted to ask you, especially with this COVID crisis, and it seems like any crisis, it seems like it's oftentimes much quicker, more effective, et cetera, to work with, individuals and your colleagues than it is, waiting for policy and government institutions to provide support. And I was able to get KN95s and kind of treatment protocols from colleagues in China who said, watch out, and this is what you should do, and here's what we've been doing. And so I was wondering if you had, any guidance or advice, for how we as individuals can support each other when these types of crises can happen, while we're waiting for kind of the larger guidance or more help from regulatory bodies.
Yeah, this happened during Ebola too. We always talked about, we were learning things at bedside. I mean, I remember in the beginning of August, I was seeing Ebola patients and I was like, wait, does Ebola cross blood-brain, barrier? Like we were seeing patients that could have cerebral malaria or Ebola, and we were learning things, right? And everybody was learning those separately rather than being able to share. And there was always this conversation about how do you create this real-time connection. And I haven't really found. There was a therapeutic learning system set up by HHS. I don't think it was used that often, but here in the US, that was one platform that was used where people could share experiences in patient and not just, supportive care, but also their use of therapeutics and compassionate use type of stuff. I don't know how widely used it was. I mean, I don't know anybody who used it, partly because it was government sanctioned, I think those types of resources could be maybe taken on board by professional societies, even if you could create those types of venues, particularly in trusted professional societies, that would be one way to create that real-time communication.
Question about PPE. Wonder if you can speak in a little more detail about the supply chain weaknesses that were exposed in this pandemic and how they can be remedied in a cost-conscious way.
So there are a couple of things that came out. One, they're just, one thing is PPE hasn't changed. I think we all know that in decades. And even before this outbreak, like we would struggle for my unit because there was such monopoly in things like PAPRs and things like that. And so, every biocontainment unit in the country invested thousands of dollars in this MaxAir PAPR. And then MaxAir decided they weren't going to produce any more of that. So they weren't going to have any more of the disposable components of it. So everybody had to reinvest because MaxAir decided they were no longer going to support it. They had to reinvest, right? There's not enough. Everybody felt there wasn't enough input from NIOSH and ensuring that there's innovation. So one is there's just been a lack of innovation, that there's a monopoly. Two, I think, what we saw was that we weren't creating enough and we didn't have enough in our stockpiles when we started this whole thing. And some part of this you can't help because PPE does have shelf life. Take it as someone who's been doing stuff for a really long time, like over time, Tyvek coveralls and things like that start getting less reliable. We saw tears and things like that. And so you do have to take that into account. But I do think what you're going to see is more in-country manufacturing, which we weren't seeing before. Is that a good thing? Is that a bad thing? It's a thing. I think it's probably a good thing. If you're patrioting sort of the manufacturing of PPE will ensure that next time there's a pandemic, and unfortunately, take it from me here today, there will be another pandemic in our lifetimes. And that would be helpful to have something closer.
Thanks. I know we're keeping you from your other meeting, but maybe one more question. And as a follow-up on the social determinants of health question, addressing social determinants of health in any fashion is an immediate money-losing strategy, even though it's a money-saving strategy in the long term. How can we change, well, this is a big question. How can we change fiscal understanding on a national level from where we stand here on a local level, and whether it's at Robert Wood or in Boston?
Yeah, if I could solve that, I might have been one of the ones who won the Nobel Prize this week. But I think the gist of this is it's hard because our politicians don't represent us, and there is lack of science understanding. So it goes back to, educating, either having more scientists and doctors in government or educating our public a bit more about the importance of these things. Because but it's the same thing is true of everything in pandemic. You know, preparedness is such a hard sell. Disaster averted is hard to prove, right? And this is sort of the gist of my entire existence of why I never get promoted. Just kidding. But the difficulty in this is disconnecting the political cycle from investment in these types of things. And it is everything from access to healthcare, reliable healthcare, and making that a human right. You know, if we just did that, we can't even agree to that. And the politicization of something like that, I do think it is something more basic, and it has to start with electing people that represent our priorities.
Bravo. Thank you so much. It was fantastic. Lots of applause on the chat box.
Thank you, guys. It was a pleasure. And it was so great to see old friends again as well. Leanne and Dave, I'll connect with you guys another time.
Bye. See you soon.
Bye.